very important topic, sir. So, as we all know, can you proceed, Vijay? As we all know, a lot of pandemics have occurred, and the world has seen so many pandemics as seen in this slide. And currently, we are unfortunate enough to face one pandemic, one of the major pandemics, that is COVID-19. And in this context, we have framed the concept for this panel discussion: the recent global pandemics and the rise of otolaryngology as a global community health power. This is a panel discussion with eminent otolaryngologists of the region covering the entire state of Tamil Nadu. So, introducing the panel, as Sir has already introduced, I'll go fast. The eminent panel consists of Dr. Ali Sultan, Professor and Head of Department of Coimbatore Medical College, happens to be the President of the Coimbatore District AOI also, an Executive Committee member of TNAOI, representing from the northwestern part. Dr. Dinakaran, Professor and HOD of the Madurai Medical College, currently Secretary of District AOI of Madurai, and he's from the southwestern part. Jairamachandran sir, a Senior ENT Surgeon, Salem, and currently the President of the Salem District AOI from central part. Dr. Muthukumar sir, Director of the Upgrade Institute of ENT of MMC and State Nodal Officer and Executive Committee of TNAOI from the Capital Zone. Palniappan sir, a Professor and HOD of the ENT Department of Tiruchirappalli, and he's from the Central Zone. Pradeep Kumar from Hosur, an ENT Surgeon, Secretary of the Dharmaburi and Krishnagiri District AOI from the Northern Zone. Dr. Raghunandan, ENT Surgeon from Madras ENT Research Foundation, Executive Committee member currently and Treasurer of the South Zone AOI from the Capital Zone. Dr. Ravi Kumar sir, Senior ENT Surgeon, Pro Vice Chancellor of SRM University, Chennai from the Capital Zone. And Dr. Ruby Albert, Professor and Head of Department of Krishna Medical College, Vellore from Northeastern part. And Dr. Siva Subramaniam, Associate Professor of Tanjavur Medical College, Eastern Tamil Nadu. And Dr. Suresh Kumar sir, Professor and Head of Department of Tirunelveli Medical College, President-elect at the beginning and end of this program is going to be the President District AOI Tirunelveli from Southern Tamil Nadu. So welcome you all for the panel discussion, sir. So moderated by myself, Gauri Shankar, and my gratitude to Professor M.K. sir and all my teachers for the opportunity, and Dr. Vijay Krishnan for all the technical support. So first, as we all know, sir, a lot of pandemics we have faced, and of the pandemics which we have encountered, or some of the epidemics which we have encountered, most of them present with our ENT symptoms. So in this context, we would like to get the opinion from the eminent panel regarding what are the recent epidemics that have predominant ENT manifestations as the presenting feature. So this will be enlightening the audience and everybody of us. So Dr. Ali Sultan sir, can you please give your opinion, sir? Dr. Ali Sultan sir? Yeah.
Gauri, I don't see him logged in here.
Okay, sir. Dr. Palniappan sir, can you just contribute to this answer, sir? Palniappan sir?
Sir.
Yes, sir.
They are COVID-19, Ebola, and Nipah, and in which the COVID
Sir, Palniappan sir, audio is not clear.
In which the ENT manifestations commonly hello?
Yes, sir.
Hello?
Yes, sir. Now it is
hello,
audible.
Is it audible?
Now it's audible, sir. Previously it was not, sir.
Yes, sir. The recent pandemic, the common ENT manifestation: headache, sore throat, and loss of smell and taste, and dry cough. These are the common manifestations what we are facing in the ENT.
Okay.
Hello?
Yes, sir.
Yeah.
Sir, thank you.
These are the common symptoms what we ask.
Okay, sir. Yes, sir. Thank you very much, sir. Dr. Jairamachandran sir from Salem, sir. Can you contribute furthermore to this question, sir?
Well, I managed to get some statistics here.
Yes, sir.
The Russian flu was in 1889.
Okay, sir.
And the number of people affected was 165 crores.
Okay.
And there was 10 lakh deaths.
Yes.
The Spanish flu was in 1918.
Okay, sir.
And the number of people affected was 180 crores and
Okay.
50 lakhs death.
Yes.
The Asian flu was in 1956 to 58, so almost
Yes.
2 years.
Yes, sir.
And 292 crores and 15 lakh people dead.
Okay, sir.
Hong Kong flu
Okay.
was 300, that was in 1968.
Okay,
So
sir.
355 crore people affected and 20 lakh people dead.
Yes.
And of course, not so long ago, swine flu, 2009 to 2010,
Yes.
the number of people affected was 692 crores.
Yes,
And
sir.
fortunately, only 19,000 deaths.
Yes, sir.
And of course, right now we are in the SARS-CoV pandemic. So
Yes.
far, it is 780 crores and counting. And I
Yes.
think so far we have 10 lakh deaths and still counting as well. So
Yes.
as we hear, apparently the Europe has gone for complete lockdown again. I mean, at least Spain has gone down for lockdown again. And the
Yes.
latest news is there are about 1 lakh cases reported in Europe, throughout Europe. Of course, Europe is significantly smaller than India in terms
Yes.
of population. So
Okay.
1 lakh crore people affected in the last day or so.
Yes.
So this is some, of course, if you want to take AIDS as a pandemic, that is
Yes.
also, of course, not included in this. That's another pandemic we should take into consideration, and it is still ongoing.
Yes. So almost leaving few epidemics and pandemics, most of the pandemics have ENT manifestations, sir. Does the panel agree with this point, sir?
Yes.
Yes. Yes, sir. So thank you very much, sir. We'll, with this, at the end of this first question, sir, we do agree that most of the pandemics have otolaryngological manifestations, sir. So can we proceed to the next question, sir?
Yes, sir.
Yes, sir. So with all this, do we think with these ENT manifestations, the role of first otolaryngologist is significant in early detection and prevention of spread, sir? So this is the point for the second question, sir. So we'd like to have Dr. Ravi Kumar, sir, to contribute to this answer.
Well, good evening, everybody.
Good evening, sir.
To qualify as a pandemic, one needs to know that it has affected the whole world across the continents.
Yes, sir.
And what is the most effective way of spreading? Is by close contact. And also a particle, a virus particle or whatever pathogen, which can survive all across the world in extreme temperatures and different varying temperature as well as humidity conditions. So we need these two aspects to be looked into. And which is the commonest point of entry? The way we breathe, the way we eat. So the nose and throat is part of ENT. It's hardly surprising it spreads that way. Leprosy was spread, they thought by touching each other. It was not so. It was spreading through the mucous membrane only first. So similarly, every pathogen tries to identify a portal of entry in the human body where it is susceptible, where the tissue immunity matters. And if the virulence of the organism is so good, so strong, it will definitely pass through this. So in this case, ENT surgeons have a huge role. If you see a particular illness coming up very often in the same group, in the community, it is our duty to warn the authorities concerned, take note of it, start preventive measures before it starts spreading like wildfire. So primary prevention itself is important. Detection is very important. If we treat it as a common cold or a sore throat or a tonsillitis and leave it at that, we are not progressing in science and we are not contributing to the community. That's my opinion.
Yes. Thank you very much, sir. So, Dinakaran, sir, any opinion from your side, sir? Professor Dinakaran, sir?
Yes, yes. Sir, repeat the question, sir. Repeat the question.
Do you think with these ENT manifestations of the epidemics and pandemics, the role of the otolaryngologist is significant in the early detection and prevention of spread?
Yeah, of course, sir. Usually, most of the patient come to ENT with the complaints of sore throat,
Yes, sir.
and then followed by the olfactory function,
Yes.
inspection, then dyschezia.
Yes, sir.
Then laterally, patient go for a mild dyspnea, sir.
Okay, sir.
So what routinely we do, actually we are the first day sore throat, the second day, third day, the patient may go for anasthma olfactory dysfunction and loss of taste also.
Yes.
Sometimes go for headache also. These are routine manifestations frequently we are seeing in our Madurai, sir, actually.
Yes. Yes, sir. Okay, sir.
Okay, nice.
Ali Sultan, sir, are you available, sir? Not available.
Look at the
Yes, not available. Muthukumar sir? Okay. 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 So with this, we'll go to the next question, sir. So it is agreed that we have a significant role in early detection and prevention of spread of the pandemic.
Yes, Gauri Shankar.
Yes, sir. So third, what are the limitations, sir? We have more role, but what are the limitations in the role of the otolaryngologist in the pandemic and epidemic management? We cannot be doing everything, sir. So this, we want Dr. Raghunandan to come out with the answer, please. Dr. Raghu.
Good evening to all the senior expert panelists. It's a pleasure to be part of this very hot happening topic. We are in the midst of a pandemic. And in fact, it's unbelievable that I'll be facing one pandemic in my lifetime. This is possibly the first pandemic for most of us. In fact, being an ENT surgeon in the midst of a aerosol generatable pandemic is all a big challenge, isn't it? So, of course, we do have a lot of advantages because we are at the portal of entry. In fact, we should say that we are the warriors at the entry portal of this very elusive virus. We do understand that even though the virus enters through the droplets transmitted in the air and also by contact with people coming through from the nose and the throat, most of the manifestation seems to be pulmonary. Okay, so it's a respiratory virus. So many times the major issue that I actually possibly encounter, and also I think many of our colleagues would agree, is that asymptomatic transmission. Because we are not really able to pick up which patient who's walking into our clinic is actually carrying the virus with us. And that is the reason that we are very particular about the screening measures, which will give us a judgment, like temperature checking and taking a history of contacts, possibly moving through the different phases of the pandemic. We've got to be extra cautious. The limitations may be that we are actually facing a scenario where simple case like tonsillitis or upper respiratory infections cannot be a simple viral cold. The very terminology of a common cold is gone now. And we are looking at, we are trying to rework the actual definitions of viral upper respiratory infection. So I feel that we got to be more cautious as ENT surgeons in identifying those cases which may be COVID. And in fact, we are nowadays seeing a combination of variety of presentations in ENT, which are possibly predisposed due to COVID. So we don't really know what is the way or the mechanism by which these manifestations like anosmia, loss of taste. In fact, we've seen vocal cord palsy, we've seen sudden hearing loss. Surprisingly, it possibly seems like a neurotropic virus. So we need more screening tools, and we need to have a clear history for documentation of the manifestation of this virus. And that would really help us to identify the cases, refer them appropriately, and start them on treatment before they actually go into develop respiratory symptoms. I think that's the limitation that possibly all of us as clinical practitioners in the midst of a pandemic should.
Thank you, Dr. Raghu. Is Dr. Ruby Albert available?
I'm here, Gauri.
Yes, ma'am. We want your opinion regarding this.
Our limitations are we are in a field where we have to look into the nose. We have to look into the throat. We cannot avoid doing it. However, we should be judicious in only doing warranted endoscopies and procedures. We should limit our uncalled for endoscopies or other diagnostic procedures. For a simple allergic rhinitis, which we can pick up clinically, treat the person instead of straight away going for an endoscopy or something invasive like that. Because we are generating aerosol, we don't know who is positive, we don't know who is asymptomatic carrier. So it would be prudent to be careful in whom we do procedures and why.
Okay, ma'am. Okay. Muthukumar sir? Sir, is not available. Okay, sir. We'll go to Suresh Kumar sir. Can you give your opinions on this?
Yes, sir. So the limitations for this pandemic, usually sometimes it presents with general symptoms, mainly fever, cough, headache. At that time, they used to go to the family physicians or the general practitioners than our ENT people.
Okay, sir.
Second thing, So even if the nasal symptoms, even minor nasal obstruction, nasal sneezing or sore throat, they are getting anxious and they are coming out, and as Professor Ruby said, they want to be examined thoroughly. So see me, my throat, like that. With complete anxiousness, they used to come to our ENT clinic or OPD. So we are unable to avoid them. Instead, we have to look into them sympathetically. We have to see the throat. So there are so many limitations with the help of the disease itself. Third one is the number of ENT surgeons. We are very limited as far as concerned. I faced in our Tirunelveli Medical College, we are 4 assistants only. So even the number of duties looked after by them are more than what the physicians are doing generally. So they are almost 32. They used to see once in 2 months the COVID ward duty and non-COVID, whereas our people routinely they have to go by each and every for 1 month or within 21 days they have to go for 7 days COVID duty. So there may be we are more of punishment. This like that. So we are, since being a frontline warrior, the initial stages we are forced to take or the nasal swab as well as throat swab by ENT PGs alone. We are only 4 PGs, almost taking 200 or 250 swabs per day. It is highly pathetic. Then we started educating the other PGs and the other assistants also to do so in outsides. So there are so many limitations. These are few seen in our institute. Any more experience, sir?
Sir, we want the opinion from Ravi Kumar sir. We want your opinion. What are the limitations?
I think the limitations are that we first of all refuse to recognize what we're seeing.
Yes.
We should actually be aware that the diseases are all airborne and they're spread by viruses which are going through the aerodigestive tract. And one of the first things I must advise everybody is from now onwards, please keep wearing a mask whenever you examine a patient. That was a habit which was taught to me when I was a student, and I still follow it. I think so many ENT surgeons have lost their lives also because of a simple precaution they have not done. There is no limitation in that. It's just a question of habit. Secondly, reusing instruments, another reason why it spreads from person to person. We should start adopting the spatula, the wooden spatula, rather than using a tongue depressor. Yes. We should also try to educate our co-workers. There's no limitation in that. To train them how to prevent these infections from spreading. The limitations really are the tests. If you suspect virus, what do you do? That was the biggest limitation which we experienced in our hospital, because our hospital did not have the lab which could do the RT-PCR. So once one patient is suspected of having a COVID virus, we have to actually wait for 24 hours to plus 36 or 48 hours sometimes to get a result. In the meantime, he was spreading the virus to others also. So we need to have much more testing facilities available. That is a big limitation. Even if you suspect, how do you confirm? Without confirming, you cannot really brand a person as having a COVID positive illness. Then the other limitation is how to explain the whole thing to the family and the people around that patient, suspected patient, to stay away from him or to keep in isolation. These are the other limitations. So health education becomes very important, which none of us have the time to do it. And we should involve the community medicine people as well as health workers in this spreading of information. Plus the media is a huge source of information dissemination that should be used. Local media should be absolutely on the one side of the page when it comes to the ENT manifestation. They should be putting it in all their publications as well as the radio and TV, etc. That goes a long way. You and I telling alone is not enough. That limitation can be overcome like that. And finally, teaching our younger generation, the PGs and the students, how to take precautions. I think that is another thing. We don't have time for it. Time is a limitation. But if you make the effort, the word will spread, and we can avoid such things happening again and again. See, the swine flu, the bird flu, and all were there. they also spread the same way. We didn't take the warning very seriously. And now this virus hit us like a pandemic, like a tsunami, and we are all suffering together. We should learn from this and avoid such limitations coming our way.
Yes.
Thank you.
Thank you, sir. Any other opinion from the panel, sir? Any other opinion?
From Trichy side,
Yes.
sir, from Trichy side, I'm talking.
Yes.
As Dr. Suresh told, in our hospital, 4 of our house surgeons, they contracted, and a PG contracted the disease. So, because they are repeatedly exposed to COVID wards and other things, okay. So, inside the government setup, all the doctors, ENT doctors, very limited ENT doctors, they are exposed. And in outside, that is in our Trichy Association of ENT Surgeons, 3 leading ENT surgeons contracted the disease. So we are afraid to see the throat infections, but even then we have to do that, because for the sake of the patients we are doing. So we are at the risk. Actually, ENT surgeons are vulnerable for all these things because of the aerosol spread. No, so we are contracting the disease much. So we have to be very careful in that thing. So we have to protect our junior colleagues as well as the seniors. Very important. Our seniors are also important, and they are contracting the disease in this pandemic. So we have to be careful. That is a limitation for our ENT surgeons.
Gauri sir.
Yes.
So first of all, as a frontline warriors,
Yes, sir.
we should be take precautionary measures in the OP and theatre also.
Yes.
So most of the procedures are aerosol procedures.
Yes, sir.
So what in the theatre we have to put the negative control pressure, like
Yes.
that you put, and moreover, first you have to select the case, which one is emergency, which one is essential, which one is mandatory, or electives, like that. Prepare the cases like. So
Sure,
most of the during this class, what we covered, what tracheostomy, ENT surgeons should do, and moreover, foreign body larynx would do, and sometimes we have a lot of allergic fungal sinusitis in this period. So we have to prepare for endoscopic sinus surgery. Like this, these are the emergencies, like foreign body or tracheostomy, what and allergic fungal sinusitis, foreign body cricopharynx. These are the essential. We have faced a lot of cases in our faculty. So for that, we have prepared as a respirator. The high solution respirator is very, very essential rather than the face mask and the face shield. And moreover, Pakka theatre with negative pressure control rooms. And moreover, you ask our, we have to protect the PGC Pakka PP kit. Without PP kit, don't do this procedure. See a viral load, so more common in nasal cavity and nasopharynx and oral cavity. So most of the OP procedures should be abandoned actually. So we ask the clinical manifestation like when in rhinorrhea, nasal congestion, or sometimes nasal obstruction, or sometimes the sore throat. What are the things you go give the conservative management, like what you already we protocol one paracetamol or antibiotic or anticoagulant or nasal drops, like that we have given and managed the cases. Actually, almost we closed the department. Now only we are seeing 80 cases per day. Even though the most cases are we are facing, we are preparing the cases like that. Which one is mandatory, which one is essential, which one is elective, like that we are preparing the cases. And our PGs are also going do the duty for COVID, and also they are providing everything. Moreover, this is health education is very, very essential. What are the cases you have to see? What are the cases don't do? So like that you have to see the cases. And what should be always should be clean with Pakka protocol, like your social distance, all those things we are protecting. And hand disinfection is very, very essential. These are the protocols what we are facing in our department. And moreover, no PGs are suffered in this COVID positive actually so far. So these are the protocols. So you have a Pakka hearing mask, Pakka theatre setup, and Pakka OP procedure you have to see, which is essential surgical cases. All these things put in your mind and do the cases, will get success.
Yes, sir.
Thank you, sir.
Thank you very much, sir. So the major limitations being we are exposed to aerosols and we are reluctant to get exposed without adequate protection. And what I feel is a proper knowledge on community health and preventive aspects, and proper knowledge on general medicine aspects also, apart from ENT for the postgraduates, will help us get adequate knowledge and protect ourselves in the future, sir. This may not be the only pandemic which we'll be having in the future. So we'll go to the next question. So, what is the role played by the ENT surgeons in the current pandemic? This has been already answered by Dinakaran sir and Suresh Kumar sir. But anyway, we would like to get the answers from hospital-based and individual-based. So we'll try to get from Dr. Raghu. What is the role played by ENT surgeon in the current pandemic? Your answer, please.
I think we should classify the role as those ENT surgeons who are involved in active COVID service,
Okay.
and those who are in private practice taking protective measures against COVID.
Yeah.
So I think the roles are entirely different. And of course, as Professor Dinakaran had mentioned, and also Dr. Paniappan, so those are actually the roles that are played by ENT surgeons who are being posted in COVID wards. And they are the ones who should take much more protection for screening patients, for starting treatment, for serving them in the wards, and also taking up to theater and follow-up care, etc. But in general, I think there is a larger crowd who are not into active COVID service, but are in the midst of this pandemic. And possibly there is not a general consensus on what are all the protective measures that needs to be followed, especially in private. So, of course, as an individual, it is much more challenging to face COVID all by yourself, rather than being in an institution where all the protocols and setup are very organized. I think it will be much safer for us to work as an institution with very clear protocols for all the staff and faculty and assistants, etc., rather than being an individual practice. So I think there is a varied role for all of us in this pandemic. Yes. But each of us do have to take due care and play this role very carefully.
So currently, ENT surgeons are helping in nasal swabs, that is in investigation aspects, and also taking part in treatment aspects, also doing duties in the COVID wards. So that is the current role played by ENT surgeons. Dr. Sivasubramaniam from Tanjavur, can you just explain what is going on? Can you just explain?
Sir, good evening, sir.
Yes.
Yes, for ENT surgeons, early detection and cases is a major role of ENT surgeons, sir. Early recognition and insisting the patient on hand washing, masking, and social distancing, sir.
No, that is all what is followed by everybody. But what is the role played by ENT surgeons in your hospital in this COVID pandemic?
In our hospital, keep social distancing, hand washing, frequent hand washing, usage of N95 masks, and seeing patient in the 15 minutes intervals for each patient, sir.
Oh. Dr. Pradeep? Dr. Pradeep?
Yeah.
Yeah.
So, good evening to all the senior panelists, Professor Muthukumar, Professor Paniappan, Professor Suresh Kumar, everybody. Sir, the role of an ENT surgeon, I see in a different perspective. Okay, we all talked about how you see the patient, but I see we play a major role in this pandemic. Okay, especially most of the patients, let it be COVID or non-COVID, we are the people who meet them first. Just by analyzing the entire symptomatology, we can differentiate whether this patient is a COVID or non-COVID just by the symptoms. And by doing that, we play a major role by making them understand about the disease process, and we are educating them about the disease, and we can tell them what next test has to be done. So by this, we play a very significant role. What we do here is the patients, what I see is the moment I see it is not in a regular rhinitis patient without any facial pressure or anything, just nasal block with minimal rhinitis and a sore throat. There is no significant postnasal drip. I tell them that this could be COVID. So by sensitizing them, by educating the patient, definitely we are playing a major role, so that we are segregating the patient from others, and we are subjecting them for the other investigations. And by doing all these measures, in my practice, we have seen almost 80% of patients turning out to be positive for COVID. Apart from that, all the regular measures, as other professors and Raghu has told, we are taking all the precautions.
Thank you, Dr. Pradeep. So we welcome Professor Muthukumar sir to the panel. Sir, we would like to have your contribution towards this answer, sir. What is the role played by ENT surgeons in current pandemic?
I think most of the precautions have been covered, except that Professor Dinakaran told that the regular endoscopies, especially the video laryngoscopy aspect, given antiseptic mouthwash to the patient just before doing the video laryngoscopy, either betadine mouthwash or in fact, I've been practicing this dilute potassium permanganate solution, which is used for antiseptic as for drinking water wells. So that potassium permanganate or dilute betadine mouthwash before the procedure helps in the in preventing the spread, the contagious nature of the disease. So that is one important point which I want to highlight. Before doing endoscopy in Rayapeta, I think Dr. Chamala Sarvan was the other day I was talking. He was practicing this regularly because it's a non-COVID hospital. He used to advise betadine mouthwash regularly for all the patients before doing video laryngoscopy.
Okay, sir. Thank you, sir. Dr. Ali Sultan, sir, have you joined, sir? Are you here, sir? Okay, sir. So with this, we'll go on to the next question of the for the panel, sir. So regarding research, sir, we'd like to get the answer from the panelists regarding research pertaining to the pandemic. So any work going on so that we can learn and we can also follow. So anybody, sir, open to all panelists?
I think one thing we can consider is what is the cause for anosmia, because anosmia seems to be a very significant issue and everybody is talking about anosmia and agousia. And if it's possible to do a research on the mechanism of anosmia and agousia, maybe I think that is one thing we can consider.
Yes, sir. Any other?
Gauri,
yes, sir.
in our college, we have advised our PGs to go for this research. That is povidone iodine spray, virucidal activity.
Okay, sir.
Prospective and double blind control.
Okay.
Paper allotment, and we are using steroids. So, what is the use of steroids and the evaluation in anosmia in patients with COVID-19? And another important thing going on is effectiveness of the nasopharyngeal swab and bronchoalveolar lavage, RT-PCR study.
Okay. Are
Like
they going on in our department?
Going on. Yes, yes.
Nice, sir.
Gauri.
Yes, sir.
In our Tirunelveli Medical College,
yes,
along with the microbiology, we are comparing the salivary samples with nasal swabs for identification of COVID-19 in COVID suspected and affected patients.
Right,
so they are taking all the people,
yes,
the incidence, detection rate, sensitivity, and viral load between the two, nasopharyngeal swab as well as the salivary samples.
Yes,
Dr. Gauri, one important point which I want to highlight is that whether the middle ear is free of the virus or not. For that, I have suggested a study. We have started doing meningoplasties, and then we'll and then next few days we'll also start mastectomies. We will be taking swabs from the east station, the middle ear end of the east station to orifice, as well as from the mastoid mucosa. To see whether virus is present or not. That study I proposed to the microbiologist. I think if they accept it, we are going to initiate that study.
Nice, sir.
Gauri sir, we have given the cases for olfactory dysfunction. So in this COVID period, which day is going to start? What are the causes for? These are the given. The second cases we have given CT paranasal sinuses comparison to the allergic in relation to the allergic fungal sinusitis in the COVID period. So we are getting a lot of cases in this period allergic, but the entire scenario is different from routine allergic fungal sinusitis, where you can keep all the necrosal mass we can see in the alroad. So that the medial maxillotomy done actually happened. What we are routinely doing on the endoscopic procedure, already the medial maxilla has eroded in this allergic fungal sinusitis case. So these are the routine we have given. Apart from already the Suresh Kumar said that the nasal swab studies are going here only.
Yes, sir.
Okay, sir. Nice.
Yes, sir.
Previously, we thought between nasal and oropharyngeal swab, but it will not be that much useful. So the microbiologist suggested the salivary sample is to be compared with the nasopharyngeal swab, like that. But actually, we suggested that the nasal swab will be better because we can take it from the nasopharynx, whereas the oral maybe from the oropharynx, sometimes from the nasopharynx, so may not be true depending upon the person who is taking the swab.
Yes.
Second thing, the throat swab may produce a vomiting or gag reflex, producing aerosol, whereas the nasopharyngeal swab will not produce. So there are some advantages, disadvantages we have suggested, but microbiologists suggested salivary sample, the reason being. So another proportion is a sudden sensory neural hearing loss in post-COVID patient. I have read about only one. So the patient is coming with a sudden hearing loss, only one patient, but accordingly, but our audiologically he seems to be normal, mostly anxious only, but we can plan for sudden sensory neural hearing loss in post-COVID patients.
Gauri, if I can mention, I was fortunate to be part of the TNAOI2020 group, the International Federation of Otolaryngological Societies.
Yes,
in fact, at the start of this pandemic, right from January until June, they had done a worldwide global survey of about 6 months across different subspecialties of ENT, looking at the various morbidity and mortality factors influencing ENT surgeons. Of course, for India, it was a little premature because most of our first wave was slowly picking up. And at the end of the survey, in fact, I could contribute only one ENT surgeon from India and from Mumbai who was actually part of this, who had developed some morbidity. And so the overall survey, starting right from Wuhan, we had included Chinese ENT surgeons as well. Most of the mortality at that point was in Spain, Italy, many parts of Europe, and it was just peaking in. So most of the data was westernized. And they had reflected that almost about 10 to 11% of ENT surgeons who had been afflicted with the virus actually had significant morbidity and mortality. So that is a very high percentage. So obviously, of course, these people were in active COVID service. Very few of them had picked it up out of normal private practice or not being in taking full person protection at the time when they were not exposed to COVID service. So that is an important part of the study, which is ongoing. Now they actually taken up the second part of the study, which started from July. And this will probably reflect better for the Indian perspective.
Excellent. Nice. Yes, sir.
Gauri,
yeah, just to add on to what Dr. Raghunandan has just mentioned,
yes.
We did a survey of the amount of aerosol generation which is happening on the ENT postgraduate or the surgeon who's taking the swab.
Okay,
and found it was safer to take it from the oropharynx if you use a proper spatula and know how to use it and use that shield.
Yes.
We also sample the expectoration which comes out in case they cough or anything, and then we found a high rate of infection in that also. Besides this, the ENT is contributing along with anesthesia in knowing the safety of using high flow volume nasal oxygenation compared to doing intubation, and they found that this former was better than intubation or tracheostomy. Tracheostomies have become rarer now after we found this finding. Besides this, our hospital is doing 3 important research projects on along with Siddha Institute, but they are not of ENT background. They're trying out Siddha medicine for this Kapasuga Kudini, very effective, and also some Siddha medicine. They are all India research projects which are going on in our hospital, along with the vaccine trial. Thank you.
Thank you, sir. And any answer from Christian Medical College Vellore, Dr. Ruby? Any answer? Any project going on there?
Sorry, there's research and more research being done by various departments. But ENT, we haven't put out many things. We are actively working with COVID. We have, this is to Dr. Suresh Kumar, that ENT surgeons are being stressed out doing the swabs. We have taken it upon ourselves right from the beginning of the COVID to train other personnel. So now it's almost taken over by nurses, respiratory technicians and others. So we are routinely, in the beginning, it was only ENT doctors who were there. Any doctor can do. I think all have forgotten anatomy and nasopharynx and they behave that it's only the ENT person's perspective to do this. So we have been very busy. We have not collated our things.
Okay. So a lot of ENT manifestations, lot of pandemics, and lot of research prospects are there for us. And one thing which we have, to my surprise, we have taken more than some 20,000 swabs we have taken, but not a bit of epistaxis we have encountered in all the patients. Any answer from anybody, sir? Any epistaxis we have encountered while taking nasal swab for COVID?
No, so far no. So far no.
Yes, sir.
Gauri, can I just add on a little bit here, even though I'm not in the panel?
Yeah, please, sir. Yes, sir.
No, actually, it's a very interesting point which Jairam Chandran brought up is anosmia, right? And there's a lot of work which has happened there. You know, anosmia, interestingly, is a temporary anosmia. Usually, it recovers in about 2 weeks' time, on average, up to a maximum of 1 month. The main mechanism is the damage to the sustentacular cells. You know, it's not actually to the olfactory epithelium, which is why it recovers. The sustentacular cells have a very high expression of ACE2 inhibitor receptors and also TNAOI2020 receptors, which are both the entry points of the virus.
Yes,
so it's damage to the sustentacular cells, which will recover, you know. So unlike the olfactory neurons, because there was initially a lot of concern that anosmia may mean infection of the olfactory epithelium, which would then form a direct route to the brain, because olfactory epithelium we know is nothing but an extension of the brain, and it has CSF actually around it. But now we know that the infection is not to the olfactory epithelium, but it is actually to the sustentacular cells, which is why it recovers in about 3 to 4 weeks' time. The second point about why there is no epistaxis is because there's very little damage to the nasal mucous membrane, even though the entry point is the nasal mucous membrane. The virus soon leaves the nasal mucous membrane and gets into the system, into systemic circulation. But it does very little damage to the actual nasal mucosa. So you will find nobody will also complain of nasal obstruction, in spite of the fact that a lot of them will have symptoms like anosmia. They still will not have any nasal obstruction. So the damage is not to the nasal mucosa, but it is actually a point of entry for the virus. Now, regarding the research projects, I think the one thing which we need to look at now, in fact, it's ideal for having a multi-centric reporting. If you can take from many centers in Tamil Nadu and report it, it will be the incidence of sudden sensory hearing loss in COVID-19 patients. So there's now a lot of reported cases which are now coming in from Europe about sudden sensory hearing loss as a manifestation. In fact, there have also been reports of bilateral sudden sensory hearing loss in COVID-19 patients. One patient in Hanover's Thomas Linnau's group had even had a cochlear implant done on them because of that. And that seems to be irreversible. So it will be very interesting if you can actually get the statistics from all the medical colleges, all the big institutions in the city and in the state about the prevalence of sudden hearing loss, if at all, in patients with COVID-19. It will be worthwhile because we can either, you know, prove it or disprove it, you know, either way.
Yes.
Thank you.
Thank you very much, sir. So this Edson loss, the Muthukumar sir being the state nodal officer of NPPC, we can coordinate with sir and we can get it done, sir.
Yes, sir. I will sensitize all the district nodal officers, sir. If any case is encountered, it has to be reported, sir.
Thank you, sir. Thank you very much, sir. So having gone through the WHO site, sir, regarding the literature, so far 1,290 articles have been registered under WHO regarding research projects on COVID, of which 114 from India, sir, from Indian side. So this is what, and we hope we'll get more increased projects. So we'll go to the next question, sir. So what would you advise regarding the precautions to be taken during ENT practice? So aerosol, all the ENT, almost all young ENT surgeons, everybody, we are afraid of getting exposed to aerosols and more concerned about our health and also. So in spite of the lot of protective devices available. So we like to get the advice from the expert panel. And regarding, yes, sir. What advice regarding the precautions to be taken during ENT practice, during outpatient, office procedures, and during surgery, sir. So we'd like to have the advice of Dr. Jairam Chandran, sir, to start with.
Well, okay. Well, I think a fair amount has already been discussed. I personally feel the thermal temperature recorder is not particularly very helpful, because sometimes it shows the temperature significantly low. But then the first port of call is the person who's sitting in the outpatient's clinic and asking whether they really have nasal symptoms and whether they have blocked nose, runny nose, sneezing. And if they are if there is any suspicion, then they are requested to go have RT-PCR test done. Then of course, then they come to the chamber. Patients do wear mask, of course, obviously. And as far as the doctor is concerned, we wear the N95 mask, face shield, goggles, and of course OT apron, double gloves, and appropriate footwear as well, and change the gloves as and when required, as frequently as possible. So this is the precaution we generally take in the outpatients. And it's not as if you don't examine the mouth. It's not as if you don't examine the nose, because patients are there. They want you, because some of these patients have been known for a long time, especially in a single-handed private practice. You can't refuse the request of the patients, and many of them are really worried whether they have COVID. Then you have to educate them, saying just by looking at the nose or throat, nobody can say whether they have COVID or not. Basically, if there is a suspicion, if there is a proper history suggestive of COVID-19, then they have to go and get the test done. So a fair degree of work is done, reassuring the patient and directing them appropriately. Say 2 days ago, I had a patient coming with severe nasal obstruction and runny nose and body ache, whatever. He's a 75-year-old gentleman, diabetic, and the son shows me what can I say, the report saying COVID-19 negative. Then we have to educate them, saying, although RT-PCR is specific, there is about 30% the false negative. So I urge them to go have a CT scan done, and lo and behold, the lung was full of COVID. So we had to direct them appropriately. So we do have to take all these precautions. And examining the ear is not a big problem, because I usually use a microscope and there is no aerosol generated there. I do use nasoendoscope and laryngoscope in the outpatients with appropriate precautions. And coming to the operating theater, in the last 4 to 5 months, we canceled about 12 to 13 cases who are COVID positive. We do routinely do RT-PCR and CT thorax. And of course, now I think there are some articles saying there's no need to do CT thorax routinely. We canceled about 14 to 16 patients in the last 4 to 5 months. And some of them are RT-PCR negative, but CT thorax positive. And of course, in the operating theater, the tests are done 48 hours prior to the procedure. And once they are in the operating theater, we just use the same precaution as we would do on an AIDS patient. We don't do anything extra. I may be wrong here, because my contention is that once they've had the test done and they're negative, and of course, I'm not treating COVID patients, they are all regular ENT patients. So I personally think that they may not be carriers of COVID. So that is I may be completely wrong there, because they could be in the incubation period. But touch wood, so far we have been we haven't been affected so far. But there is only so much precautions you can take in private practice, if you know what I mean. You can't have negative pressure theaters and so on and so forth. So far among the hospital staff, we have about 100 hospital staff, because we cater even for obstetrics and gynecology. So far, only 4 have turned out positive, and they have immediately been identified and isolated, and they're all back to normal. So this is what we have been doing. And of course, the workload has significantly dropped, and we are working around 60% of what I would normally be working on.
Yes, sir. Sir, Palniappan sir, what is going on?
What we are doing is, for the surgeons, for our department, we have given N95 masks for all the even house surgeons, PGs, and the doctors. N95 mask and face guard we have distributed to all the doctors who are the OP. And in the theater, we are asking the surgeons to go for this powered PAPR, powered air purifier respirator. And for the patients, we are advising them to wear gowns and triple layer mask in the ward. The good ventilation, even after finishing the surgeries, the surgeons are sitting together there. In our college, in the surgery department, in the professor's room, 3 of the chiefs, they contracted the disease because of poor ventilation in that room. So we learned from that, and we are advising for a good ventilation. That is very important in our rooms, good ventilation and regular disinfections. That is also very important. And other things, we are advising the patient to go for the social distance and the instrument sterilization also very, very important. So these are the things we are advising. And the important thing, N95 mask and the face guard and the more than that, the respirator helmet with the oxygen cartridges.
Okay,
sir. That are the things we are advising for the surgeons, sir.
Okay. Yeah. Thank you, sir. Any, from Madurai, sir, Dinakaran, sir, any
as a otologist, maybe we are exposed to high viral load, especially during the physical examination, the OP procedures. See the especially what routinely we are doing a nose, throat. These are the possibilities getting infection, and also you see the other intervention procedure like video endoscopic procedure, the OP. That's also we have to protect, and routinely surgical procedures. These are the routine things we are facing daily work, and in our exposing our ENT practice. Just like that, we are asking our doctors, like our PGs, always protect with PP kit. It is essential in the theater. Where in the OP procedure, N95 mask followed by the face shield. If possible, you have to put the PP kit. These are the routine what I am asking our PGs routinely doing. Whereas what already the Professor Muthukumar said in the endoscopic procedure, so you have to apply the betadine mouthwash for any VLE, or sometimes you are putting nasal saline drops in the nose. These are routine interventional procedure, diagnostic procedure. Whereas in the theater, already I told you have to pakka plan for the cases, which is the emergency, very essential. Like that, you have to prepare the cases, especially in the tracheostomy or any epistaxis cases, or in the foreign but in the cricopharynx, or foreign but in the bronchi. All those things you have to put in your mind. So that theater should be negative pressure control room. Pakka, these things should be sterilized, and you have to put the cases properly. These emergency cases previously first we started, and things. So all protocols you are following. These are the things to avoid getting infection during our ENT practice, like OP or diagnostic procedure, or in the surgical theaters. These are the things following in our department.
Okay.
Gauri Shankar, are you able
Yes,
to
sir.
hear me?
Yes, please answer. Tell me, tell the answer, sir. Yes, sir. Please.
Yeah, actually, in Coimbatore Medical College,
yes, sir,
we have done around 70 tracheostomies during this pandemic, all emergencies,
sir,
and
okay,
out of which we have seen around 5 to 6 cases they have been positive, but we have operated before we received the COVID reports.
Okay,
but so far, by God's grace, none of our PGs or assistants have got infected. So that is, I always advise them to be cautious, whether it is positive or negative. Put full PPE, and especially the problem is the infection is coming out when they are doffing the PPE. That is more important. So the doffing area should be kept isolated, and they should be taught how to doff. So that is more important. So we have seen many places the doffing PPE are completely dumped in, and again the PPE kits are kept there, and that is where we get infection. So once you are doffing in, we are getting the positive virus from the patient, and we are already out of PPE, and we acquire the infection, number one. And number two, during surgery, I always, because I have purchased off-face respirators to all of my PGs and assistants, so they are using off-face respirator. There is 3M mask, that also to prevent some extent. And actually during this period, I have removed around 12 cases of foreign body bronchus. Usually you don't get so much within 6 months, but in this area, again on 2 cases were positive. I personally did the bronchoscopy, but nothing happened. We have taken all precautions, and the main thing is precautions with the PPE and also doffing. That is more important.
Thank you, sir. Yeah. Thank you. So from any other answer, sir, how about in MMC, sir? There is a SOP being framed in MMC. Muthukumar, sir, can you please give your input, sir?
What has been reiterated that RT-PCR 2 days before the surgery, that is RT-PCR and CT test. These are the things. I would like to be confident.
Your audio is not clear,
also, so CT have to put in. Just, I think the audio is.
Hello, sir. Okay. The audio
Got
line-
disconnected, sir.
Disconnected, sir.
I think he's traveling, so his
Okay, sir.
signal may be very.
Gauri,
Sir.
can I add up?
Yes, sir.
So in our Tirunelveli Medical College, we have got a very good team and a Pakka SOP is being made.
Okay.
For OPD, they have separated into, actually it is the plain open air OPD with a shed only.
Okay.
General surgery, ortho, ENT, ophthalmic, everything as separate OPD in a PMSSY building.
Okay, sir.
For theatre also, there is a separate COVID theatre and non-COVID theatre. And we used to treat all the patients as COVID patients only, even if it is negative. So he used to sterilize. And one day, one operation theatre is being utilized. Second day, the theatre is put on the other works. So second day, second theatre, like that. First floor theatre is on Monday, Wednesday, Fridays. The second floor theatre on Tuesday, Thursdays, like that also. So like all the other precautions, I do agree with Ali Sultan. The talking and coughing is producing more aerosols. So ask the patient to convey only with the little, what is the main complaint. So I suggest don't go for all the three examinations. We used to examine in our OPD. Even if the patient is coming for nose, we will see, hear everything. Now I will confine, if it is any particular ENT, then I will go for the other examinations. Then the exposure time reduction between the patients, we have to be little bit cautious. Even we can plan. Now I am doing my OPD on Mondays and, I am leaving on Wednesdays and Sundays, all other 5 days. So 2 days OPD, third day I am abstaining from the OPD. 3 days OPD, 1 day rest. Like that I am planning. So like that we can avoid. We can utilize others also, like half mask, ventilation, everything is almost same.
Gauri?
Yes.
Hello?
Yes, sir.
So actually what I do in my hospital is, I always keep only 2 PGs in the OP. Right?
Okay.
Whenever there is an emergency, then because I have all the other PGs in the standby, but I allow only 2 PGs to be there for nearly 5 days. And these 2 PGs should be continuously seeing the patients. And always, whenever they are taking history, I make the patient to sit around 2 meters away from the examining couch.
Okay.
And once they want to examine, they go near the patient and examine, so that the spread of droplet infection can be prevented. Number one. Number two, when you're going near, you advise the patient, don't talk or don't try to tell anything when I come near the patient. So these 2 things will definitely prevent the OP infection.
Okay. Thank you, sir.
Gauri?
Yes, sir.
Yeah, I can add some more things which already have been said.
Yes, sir.
Certain things as an administrator I have done in my hospital and certain things for ENT alone.
Okay, sir.
The general thing about administration itself is that we completely rerouted the entry point and exit point of all the hospital.
Okay.
We have got an entry point which is separate from the exit point.
Okay.
And we removed all the overcrowding inside the OPD areas by keeping the patients waiting on the outside in the portico. So they only come in batches and physical distancing is maintained. By that, you are avoiding the amount of aerosol generation inside the hospital building itself.
Okay.
Secondly, when it comes to each outpatient department, especially in ENT, we have taken a precaution of taking the history outside the consultation room by a different doctor, and then he comes and presents it to the consultant inside. So the number of people in the consultation room is not more than 3.
Yes.
Patient, the doctor who is giving the history, and the consultant himself. And then we have placed acrylic shield between the patient and the doctor while all this transaction takes place. And only when the examination comes, he comes nearer to the patient. All the ENT postgraduates and people working in the ENT OP are given N95 masks, and they all wear the surgical gown.
Yes.
Beyond this, we have established a separate booth for taking the samples.
Okay.
And in our hospital, almost all the swabs are taken only by the ENT postgraduates and ENT trained people in the booth, except those in the ICU, where they wear the face shield and take the ICU or the other wards, labor ward, etc., where they go around We take on an average about 80 to 90 samples every day. It's all done by the PGs only most of the time. Lastly, any procedure being done in the hospital before the admission, I'm talking about surgical procedures when they open the hospital, they first undergo the test 2 days before.
Yes.
When they come in, if they are positive, they're sent back. If they're negative, they are admitted. If there is a query, that is, we don't know what the status is, and they require admission, then we keep them in a separate ward called a suspect ward, where we have to monitor them using all the precautions. And only when they are negative, they are taken into the regular hospitals. So the hospital has been zoned. So we had about 140 odd people in our hospital, health workers and doctors getting infected, but not one death in the hospital yet. And only one person who had a liver problem and also was on the waiting list for a liver transplant. He died in Rela Hospital. So we had survived this pandemic, even though we had infections, but nobody had serious illnesses. This includes people with comorbidities and people over 70 years old who are serving in the university. Thank you.
Thank you, sir. So with all these valuable inputs, proper application of manpower, proper application of the protective devices will be protecting the ENT surgeons over these years and over this period and also in the future also. Thank you very much, sir. We'll go to the next question, sir. Post-COVID syndrome is a new entity, sir. We have started facing patients. And what are the persistent symptoms suffered by them and how to manage? So this, we'd like to have the answer from Dr. Pradeep. Any experience of Dr. Pradeep? Okay. Is Dr. Pradeep there? Okay. Otherwise, Dr. Ruby, ma'am, can you share your inputs? Dr. Ruby is there?
Yeah, I'm here, Bobby. We've seen some isolated nerve palsies. We've seen bilateral abductor. We've seen recurrent laryngeal palsies. We've also seen post-COVID developing acute sinusitis going on into, this is in a diabetic. He had respiratory symptoms.
Audio is not clear.
Treated, was pneumonia. Post-discharge, post-quarantine, can you hear me? He came with an acute air fluid level sinusitis, was treated, and you found he has mucor.
Mucor.
Yeah. Oh. And then another thing is post-COVID suicides. Attempts and throat injuries have increased.
Okay.
Hanging.
Right.
Gauri, can I just add a quick point?
Yeah. Sir.
The most common symptom I've seen is not
yes,
ENT. The most common symptom is depression and anxiety neurosis. People are so depressed, their chronic mental stress is too much. And the same routine of going to the COVID ward every day and coming out and then following the same routine, not being able to pursue their normal career, especially among the postgraduates. We see chronic mental fatigue, and periodically we are arranging for interactions with the psychologists and psychiatrists in our hospital to boost their morale. You can look at them and you will know they're having a dull phase. They don't know what the future is going to be. Their education is suffering, their skill learning is suffering, and their exams are nearing. So this is one problem we have seen in our junior doctors. And senior doctors, I've seen the other end, they're scared to go into the ward and to see patients. This is a common symptom, although it's non-ENT.
Yes.
Gauri, if I can add a word here.
Yes, Raghu.
We have, of course, seen a variable spectrum of manifestations of COVID. But I think I should mention that the most dangerous, life-threatening complication that we've come across is 2 patients with cavernous sinus thrombosis.
Thrombosis.
Yeah, so basically, you know that this is thromboembolic. So the manifestation of the virus spreading through embolic phenomenon has resulted in very rapid spread of infection, possibly as orbital cellulitis, going in for cavernous sinus thrombosis. Now, initially, we had a dilemma of how to manage this because giving steroids is going to knock away their immunity. At the same time, what antibiotic can be probably prescribed because possibly this is a viral source. and how much of the response are we expecting? Because if suppose we need to do something, we have to work very quickly. Also, we searched a lot of literature to see whether any thrombolytics are indicated, whether any intervention would help in this scenario, etc. But fortunately, both these patients with the conventional management for cavernous sinus thrombosis had recovered. Unfortunately, both of them lost their eye in one eye. But no, I think this is something which we are writing up for publication now, because we should take it seriously, because we understand that possibly COVID is kind of potentiating the complications related to thromboembolic phenomena.
Thank you, Robert. So to sum up, nerve palsy, sensorineural hearing loss, cavernous sinus thrombosis, and suicidal tendencies causing neck injuries have been reported by these panelists so far, and we'll expect
mucormycosis also. Mucormycosis.
Mucormycosis, and in the long run we'll be adding more and more also. We'll go next question, sir. How relevant is COVID test for ENT? But this question has already been answered regarding the nasal swab and the antibody test. So we'd like to have the answer from Muthukumar, sir. How relevant are we is this test?
I think Muthukumar has left.
Okay, sir. Then Jairam, sir, can you answer, sir?
What is the question again, please?
How relevant is the COVID test in ENT practice? This has been already been answered. Just summarizing points.
Well, as I said, RT-PCR is specific but not necessarily sensitive. So I think we have to be extra careful. Even if the tests are negative, patients, we always have a high degree of suspicion. And if the patients have all the classical symptoms, it's imperative we ask them to get it retested again, and if necessary, get a CT thorax. So I don't know whether that answers your question. We have to. Okay. Is that what you're looking for? I think we have to be vigilant and ask for tests as and when required.
Because already you have told, sir, it's RT-PCR is 70% positive, but 30% negative, maybe negative. You have told already. So it is just a repetition of the question that has been asked. Any other answer, sir?
We are concentrating about this RT-PCR and CT test.
Yes.
We are giving a lot of importance to CT test, sir, because in many cases they are giving RT-PCR as negative, but the CT test we are giving a lot of importance. Even in this COVID era, we did a total laryngectomy and we did a external rhinoplasty and the orbital decompression. Everything because as we are having 2 cases of mucormycosis, and in those cases, because the anesthetists also they are also asking for the CT test, they are giving a lot of importance. So we bother about the CT test. In many patients, even ENT surgeons outside, they are having RT-PCR negative but CT test positive.
Positive.
Even our college dean, she had RT-PCR negative and CT test positive. She got admitted. So we are giving a lot of importance to CT tests, sir. And antibody tests, IgM, IgG, specific antibodies, also we are giving importance. And the false negative swabs, I think it is because of inadequate sample or some sample collection faults or the transport media when transporting the samples to the center, some faults happening. So we are giving a lot of importance to CT test, sir.
Okay, sir.
Gauri, sir.
Yes, sir.
The same things. What we are routinely doing, all putting surgery cases routinely we are taking CT test is the ideal. In our anesthesiology, people are asking CT test the ideal rather than the RT-PCR test actually. Okay. Then what we are asking other things, any cough like that, any wheezing is there. So this is a routine protocol we are following, sir.
Nice, sir. So this is the algorithm that is being followed, advised by ICMR, sir, regarding the rapid antigen test. So rapid antigen test, if it is positive, it is positive. If it is negative, it need not be negative. So we look out for symptoms. If it is symptomatic, then we have to send for RT-PCR. And asymptomatic, we have to follow up. And if the individuals develop symptoms, then we have to refer for RT-PCR. So they say rapid antigen test can also be applied with close watch, sir. So 9th question. Future ENT clinic setup, it will not be the same as we have been enjoying over the past so many decades. So how it should be modified, the individual clinics. So this, I would like to get the answer from Pradeep. Dr. Pradeep.
Yes, sir. Sir, as everybody has been discussing, the precautions what we are taking, is the one what we have to make it standardized. All those days we have been enjoying, not sometimes we wear a mask and sometimes we may not. But I think the standard protocol precautions what we have been taking now, I think we have to keep doing it further on till we feel that vaccine has come and the corona has become endemic, not a pandemic. So apart from that, any change in the clinical setup, it is very difficult for us because we mostly means we will be touching the patient most of the time, unlike other physicians. For cleaning the ears or for doing the endoscope or video laryngoscopy, we have been more in contact with the patient. So keeping that in mind, making a partition between us and the patient will be very difficult. Instead, I think we have to take a precaution on our own to safeguard ourselves.
Okay. Any other answers, sir, from the panel?
Sir, first you have to set up the separate ENT OP is ideal. Okay. For that, you have to one entry, one exit. Like that, you have to plan. Moreover, that room should be adequately, I told, a negative pressure. So AC, if you are putting AC, you have to put the negative pressure. Okay. And followed by, if some people are doing ultraviolet radiation, something, they are maintaining the temperature for killing the germs, organism, virus, and other things. Okay. And moreover, one the routine procedure, you have to put the separate protocol for the patient. For OP procedure, you have to ask the patient for mask and mouthwash and everything. Okay. And we should put the gloves while routinely doing the endoscopic procedure, all those things. And social distance. These are routine we are expecting. In future, we have to follow like this.
Nice, sir.
Gauri, I want to add one.
Yes,
that is the importance of teleconsultations.
Yes, sir.
That is also important.
Teleconsultations. Okay, sir.
But Gauri Shankar, I want to differ. But teleconsultation, how you will differ? Suppose the patient is telling I'm having ear pain. So how will you differentiate whether the ear pain is from the external ear, middle ear, or what is happening inside the ear? So we cannot tell. So teleconsultation in ENT practice, I think it is a very limited scope. So that is my personal idea. So I want to get information from Professor Mohan also.
Yes, sir.
Yes, Ali, I think it's a very valid point. Unfortunately, we are a specialty who keep looking into cavities. Yes. So we really have limitations in teleconsultation. I think teleconsultation's role in ENT has been well defined by IFOS. When you are following up a patient whom you already have seen and you know about him, for example, a patient who has got, let's say, Meniere's disease, and you put him on medication and you keep him on the follow-up, and you're reviewing him after a month of medication, and then you are saying, okay, now you can cut down your medicine. So that's the role that teleconsultation will do. So
exactly,
it was known to you already, where you have diagnosed the condition and you know it's not a life-threatening situation, and you're following up the patient, then teleconsultation can have a role. But even in patients whom you know, if it's a condition which is volatile and which can change, then again teleconsultation's role becomes very limited. So ENT, I agree with you, is not a particularly good specialty which lends itself for teleconsultation. But teleconsultation can be used in ENT to get the symptoms of the patient before he presents to the ward or to the outpatient department. So before the patient actually comes to you, you can do a kind of a mini screening via teleconsultation, and then allow the patient to come to you. Because if the patient has got frank symptoms of COVID, then he might not be a candidate for you to see. You may probably screen him at that stage and tell him to go and either present to a COVID hospital or go to but that apart, you're not going to be able to give any substantial management advice to the patient based on that consultation.
Thank you, sir.
Thank you, sir.
Can I answer your question in one word?
Yes.
One sentence.
Yes,
Future ENT clinic setup, how will it be different from past and present?
Yes.
It will be costlier for both the doctor and the patient.
Costlier. Yes, put in one word, everything. Yes, sir.
So, from the patient's point of view, they are not satisfied with the teleconsultation. Even for simple follow-up, they prefer to see your face and it will become. Like Mohan sir said, for follow-up, I tried my level best for the online consultation, but they never agree. They will once again put an appointment and they will come back for the follow-up, sir.
Yes, sir. So to put in a nutshell, the future ENT setup will not be the same, and it will be having entry and exit points with all the protective devices and much more costly also. And this is the setup which I am following, sir. I got a small booth and to examine the nose and throat and ear. I see inside, and I got a mic for the patient and for doctor also, with a fan to exhaust the aerosols. So go to the next one. And a role of stationary, currency, and reusable instruments in ENT practice. Yes, sir. So this we would like to have the answer from Sir Ali Sultan, sir. How will be the stationary and currency role?
So the currency is, I think we have to go digital. So that is to avoid, because actually the currency notes we what we get from the patient. Definitely, if the patient is a positive patient, we are going to acquire the infection from the currency note. So it is always better not to touch the currency note, number one. And number two, it is always better to go for digital transactions. It is always available with everybody. So we can go for digital transaction, number two. And number three, what I do is in my clinic, I have a UV sterilization unit. So whatever the money or what the things which are reusable, I keep it in the UV chamber, and for around 10 to 15 minutes, then I start using it.
Thank you. Any other answers, sir, from the panel? Yes, sir.
Avoidance of the rings, watches, even cell phones during the OPD, and that can be avoided, sir.
Sir, Gauri, regarding the currency notes.
Yes, sir.
You are going to do hand sanitization with the sanitizer.
Okay, sir.
You collect the currency notes and keep it in a separate box and take it after 5 days.
5 days. Okay.
You keep it dormant for 5 days. Okay. Forget about it. After 5 days, you then use it. That is the way I'm practicing, because we cannot. Or better, we have a UV chamber and keep it in the UV chamber.
Okay, sir.
Gauri sir, Gauri sir. For the stationary part, the writing prescription, everything, put the gloves.
Okay, sir.
That is, and putting the hand in the disinfection. Whereas in currency, what already Professor Muthukumar told, we are putting the money, everything will be everything in the ultraviolet chamber. Keep it for 5 days. Whereas my doubt is how we are using reusable instruments. We are putting the sterilized. That is my question. I am putting in the forum.
Yes, sir.
I have doubts regarding reusable instruments. Yes.
Number one, I use wooden spatulas. I don't use tongue depressor and throw away. Secondly, we routinely disinfect them with hypochlorite solution before we reuse. Regarding the stationery, I want to give an idea about how we are managing inpatients, especially in the COVID ward. We are not using any paper for writing case sheets. Instead, we are using magic slate, and then we are dictating the notes into the computer. There's a LAN system by which the entire case sheet is dictated and it's printed outside the ward. And when the doctor finishes his duty and leaves the ward, he or she signs off in the case sheet there. Similarly, the nurse also does the same thing. Regarding management inside the COVID ward, we are avoiding paper completely. No cell phones are allowed inside. We have a tab through which the patient and attendant or the relative can communicate with the doctor. So this is the way we are preventing infection through stationery in our hospital.
Yes.
And so far, anybody who has worked inside the COVID ward has not got infected. Only the infections came in the outpatient most of the time. Paper is a very important. You may wear a glove to protect yourself. What about the people handling the paper, especially the health workers? They are not provided with gloves. Many of the times, they are the ones who are carrying the infection. In another hospital, housekeeping staff. And secondly, the disposal of the biomedical waste. We have evolved a system where we have a separate lift, separate pathway for the biomedical waste to be taken out and thrown outside. So these are the measures to take in a big hospital. Regarding clinics, I think each one has to find his own way. But definitely, as much as possible, precautions are very important. Prevention is better than the cure, because we don't know who's going to carry the virus and how much severe you're going to suffer with the virus. And I agree that we have to trust the patient, but with all precautions, we must be able to do that. And teleconsultation, I have been using only for follow-ups, not for initial consultation. Thank you.
Thank you very much, sir. The role of stationary, currency, and reusable instruments we are very much taking care of ourselves. And one more suggestion is that we are giving back the change back to the patient and the prescription, and we should not get the blame from the patient that disease has spread from the doctor to the patient. So that also we have to consider, sir.
As they are doing in the banks,
Yes.
we can digitalize medical records like prescriptions,
yes, sir.
And even the currency, everything, UPI-based QR coding scanning system.
Nice, sir. So we'll go to the next question, sir. The influence of COVID in future conferences and workshops. This is the reason why we are here online. So having got the prestigious or much expected Rameshwaram conference postponed to next year. So what will be the influence? How the future conference and workshop will be there? So this we would like to get the answer from Muthukumar sir first.
Sir, actually, I am not an organizer. I have not organized any conference. I think organizers would be more experienced when compared to myself, being because we organize only 1 day, single day event or a 3-day event with in MMC.
Okay, sir.
So the stay part of it, hotel stay and conference with good ventilation, these are the aspects which are which go into mind, and without air condition and open at the auditoriums are the very essential points which have to be highlighted, sir.
Yes, sir. Any other answer from the panel, sir?
So I want to answer. Hello, Gauri.
Yes, sir. Yes, sir.
They are telling that in the teleconsultation, the patients are not getting interested. No, like that. Here, the conferences also. Actually, the delegates are not so interested in the online. No.
Okay, sir.
Plus the skill-based workshop.
Okay, sir.
We are getting only in the conferences.
Okay.
But when we are going to get, we don't know.
Hello.
Yes, sir.
So really, we are missing the conferences, live workshop conferences. That creates a lot of pleasure. And get together in seeing among our colleagues in a lot of meetings. That is we are missing. Another point is it's not going to continue. I think so. This year going to finish COVID. So next year we'll definitely conduct our state conference successfully, sir. Thank you.
We have to take the COVID precautions. Like even the pandemic is over, we have to allow the candidates who are coming to the conference with the hand sanitizer before they enter into the hall. And also next one is keeping a social distance, and all these things have to be emphasized for another 1 or 2 more years.
Yes, sir. So this we like to have the answer from Mohan sir. Sir, can you give some your advice?
Thank you, Gauri. Actually, I'm more interested in hearing what others have to say. I think all of you have a point. The world has changed. There's no doubt about it. But at the same time, as Dinakaran said and as Palniappan said, definitely we are missing out on physical social contact. That's a very important aspect of the conference, and that is missing. There's no doubt about it. There's such a joy when we see each other after a gap. The point of what Ali made, I think, is very valid. The next foreseeable future, next at least, I think, for not just 2 years, maybe even next 4 or 5 years, any conference in the future is going to be a conference where we are all going to be careful, wearing masks, and maintaining social distance, because we never know. The virus is not going to run away from us in a hurry. Even if we have a vaccine, even if you're going to have enough herd immunity, how long the immunity will last, how long is this vaccine going to be effective? None of these questions have been even reasonably answered. So definitely the way conferences were conducted in the past is not going to happen. We're going to be having new, safer precautions in conferences. But some form of physical meeting would be great, because we definitely are missing the social contact with each other. So we're all hoping that next year, at least by next year, we can all meet in Rameshwaram. We sincerely hope that. But it's anybody's guess. I think there's a new adage is man proposes and the virus disposes. So we have to follow whatever it says. But I think all of you have said whatever has to be said. We have to do so in the future with a lot of precautions.
Yes, sir.
And I want to add one more point. Suppose we want to conduct any conference in the future, we can just keep the conference for 1 or 2 more years in the center point so that all can travel by road. Because we have to avoid a public conveyance, we have to avoid a closed train that is AC compartment, and flying in the flying in the flight also, that's how much it is safe, we don't know. So we can have the, see, this is my humble suggestion, so we can have the conferences in the center point, so that everybody can come by road. So that is regarding TNAOI, I think we can take a decision later.
Okay.
Center point in Tamil Nadu is Tiruchi only, so Palaniappan only.
Ready, sir. We want to have all of the families, all the people ready, sir.
Late Chief Minister MGR wanted to make Tiruchi as a state capital because it is the center of Tamil Nadu.
We are also very happy to host the conference, sir. If you give us a chance, we will definitely host the conference, sir.
We are ready to host, sir.
I'm sure all of you are going to have a chance, there's no doubt about it. But I think that when is going to be the big question, Ali. We are not sure because right now, even whether next year by August, September, whether we are going to be safe is anybody's guess. I don't think anyone can reasonably project. So it seems like a very big question mark right now to me. In fact, many conferences like the World Congress and even the British Academy, they've all gone virtual. They've all said that for at least for another 2 years, 2022 is when many of the conferences are looking at meeting. So even 21, they are all very doubtful about having a conference. So this is the situation now. So I don't know when we will be in a position. I think we can only start having physically meeting conferences to somewhere towards the end of next year if everything goes well. Otherwise, even 2022. So we have to be realistic about it.
Thank you very much. So with this, as time has is running over, sir, we would like to conclude the session with 11 questions, valuable questions, and with all the valuable points from the 11 very eminent panelists of the state, sir. So otolaryngology has got a very indispensable role in all the pandemics. Having, if we maintain a proper manpower management and protective devices are being used properly, with a modified version of the clinics, surgical procedures, and a modified way of classrooms and arranging conferences, we can face the new normal in a successful way, sir. We would like to end this panel discussion with a final word from Mohan, sir.
Thank you very much, Gauri. I thoroughly enjoyed the panel, and it was excellent. Nothing less than I expected. Some very valid inputs and points from all of you. I can see that there has been a rich experience across the state. It really would be nice if we can all pool this information together. This was a great meeting point. So I think this should continue in the future also. And the TNAOI must be an umbrella for bringing together various institutions together to work out future research projects also, as you said in the beginning.
Yes.
It's a good umbrella for that, so that we can collect data from everywhere, not just with the hearing loss, but a lot of other points you've all made out. Like we talked about Mucor and COVID. We talked about all that is very interesting points, and I think it needs further study. So this will be a great mechanism for bringing all the information together, from pooling information from different departments. And the only thing that I have to say finally is, please, all of you, be safe. It's a very challenging time for us, and I do recognize the fact that we can't all run away from it and stay at home and hide behind in our homes. It's not possible. We all have to go out and work, but do so with a lot of precautions. Don't compromise on safety at any point. We already lost some very, very good colleagues in the state from the virus. Very irreparable losses. It's very saddening also. We don't, we certainly hope that this will be the last of it. Each one of you take care, be safe with you, yourselves and your families. And my sincere prayers and wishes for the safety of each one of you. So thank you for a wonderful panel, Gauri. It was excellently moderated and wonderful questions and great answers. Very good carry home points from all of you. Well, I have been educated quite a bit today. I certainly think everybody would have benefited from it. Thank you very much.
So I would request everyone to stay back. so that the members will be joining for the general body meeting. So in another 5 minutes, we will be starting our general body meeting.
Yes.